And women often ask me, Doctor, what is a hot flash? And I just say, you'll know.
Yes.
You'll know. You will not wonder what it is to have a hot flash. It is
so
a
true.
very uncomfortable, very hot sensation
Yeah.
that suddenly attacks you. And you see the ladies, they fan themselves, whether it's with a book or a hand fan, or they try to open their blouses and just get some air in,
Yeah.
because it is a very uncomfortable sensation.
Hi there, I'm Shani. As a certified health coach and kinesiologist, I help busy women in their 40s who feel tired, overwhelmed, anxious, frustrated and stuck to live their best years in great health and balance. Together, we'll explore a life that reflects intentional living and lays the foundation for you to live your life's purpose and flourish in your 40s. Welcome to Becoming You at 40. Today we are diving into a topic that affects every woman, yet is often misunderstood, feared, or simply not talked enough about. We are going to dive into perimenopause and menopause. Many women reach their late 30s or 40s and suddenly feel like their bodies have changed overnight. They experience physical changes, emotional changes, and hormonal changes, and they are left wondering, is this normal? What is happening? And why didn't anyone prepare me for this? To help us answer these questions, I'm joined by an expert in women's health, someone who works with women daily through this transition. Dr. Bianca Zondach is a specialist gynecologist with deep experience in hormonal health and midlife care. Dr. Bianca, welcome to the show. I'm so excited to have you here today.
Such a pleasure.
Oh. I've known Dr. Bianca since 2020, but you've been in practice for many years longer than
almost
that.
20.
20 years of
Yes.
experience. That's quite an extensive record that you are keeping. And that's why I'm so excited to have her here, because not only do I know Dr. Bianca and the way that she conducts her practice, but she's got such a caring nature towards her patients, and I'm excited to learn from you today. And I want to, just before we dive in, just remind the listeners and invite them to please follow this podcast. If you are a woman in your 40s who's ready to feel more confident, energized, and intentional every single day, then this is your space. So please hit follow so you never miss an episode that helps you create the life you deserve. Now, I want to begin right at the foundation, because this phase of perimenopause and menopause can be very confusing to women, and some women don't even know where perimenopause ends and where menopause begins. So can you explain to us what's the difference between the two?
So menopause is a biological stage in a woman's life. This is typically marked by the cessation or the stopping of your menstruation and a loss of fertility. Your postmenopause is once you have reached 1 year of no menstruation. Now, the perimenopause is difficult to define. It is the years, and it could be 1 year, it could be 10 years, that leads up to menopause until the year after it. It occurs when ovarian function decreases, and it's characterized typically by menstrual irregularities and all menstrual irregularities of any kind until it stops completely. Immediate results from reduced estrogen are evident in the regulation of the menstrual cycle. So that will be your first sign that you're going into perimenopause. Something in your cycle is not like it used to be before.
And what is the typical age?
So no age is the same for anyone. When it happens when you're younger than 40, we don't call it menopause, then we call it premature ovarian insufficiency or
Okay.
premature ovarian failure. Typically, this will be a woman whose menstruation stops younger than 40 and she's unable to conceive a child. Between 40 and 45, it's normal to experience any perimenopausal symptoms like menstrual irregularities and some of the other symptoms we will elaborate on later. But it is considered early. It's not abnormal though. After 45, it's common, it's normal, it frequently occurs. And the average age of women that to reach the postmenopausal stage is at 51. Now remember, postmenopausal is once you have stopped your periods for a year.
Thank you for clearing that up for us. I've recently read a book by Dr. Mary Claire Haver,
Yes.
The New Menopause.
Yes.
And it was interesting to see that she listed 65 different symptoms that women can experience during perimenopause and menopause. And that's actually quite mind-blowing to think that we can basically experience so many symptoms. But what are the most common symptoms that women complain to you about when they visit you in your practice?
Yes, so Dr. Mary Claire is correct. This is literally a head-to-toe situation. It's, once again, I don't want to call it a disease, but it's a head-to-toe phase of your life. It can affect anything. The most common is, as I've mentioned, menstrual irregularities, whether it becomes excessive or too little, whether you skip cycles or whether your cycle appears every second week, any form of irregularity. Then the one that women complain the most about is what we call the vasomotor symptoms. It's the hot flushes and the night sweats. And women often ask me, Doctor, what is a hot flush? And I just say, you'll know.
Yes.
You'll know. You will not wonder what it is to have a hot flush. It is
so
a
true.
very uncomfortable, very hot sensation
Yeah.
that suddenly attacks you. And you see the ladies, they fan themselves, whether it's with a book or a hand fan, or they try to open their blouses and just get some air in,
Yeah.
because it is a very uncomfortable sensation.
Yeah.
It lasts a few seconds and it can up to a few minutes. It comes and goes.
Yeah, and it can really be quite debilitating, and you know, you shouldn't take any menopausal symptoms lightly. I don't think we should, and it, like you said, it can be extremely uncomfortable.
So the intensity of the flushes ranges between woman to woman. So some women experience it very mildly, and for some women it's so intense that it becomes an embarrassing moment, that they feel they have to leave a room. For women in the corporate business often feel that they can't sit with a group of men around a table while this is happening. They say uncomfortable.
Yeah.
And then they lose all their confidence in what they're busy, whether it's
Yes.
during a presentation or not.
And you can't predict the timing of it.
No, no. Typically, there are some things that will bring on a hot flush, and anxiety is one of them. So when you're in a stressful situation, that's when it's going to hit you the hardest.
Yeah.
Yeah. The other form of vasomotor symptoms is the night sweats. Now, women will tell you that they wake up and it's almost like you have a body clock. My patients say, Doctor, every night at 2 o'clock,
Yes.
every night at 3
I've
o'clock,
heard that as
I
well.
wake up, I'm in a puddle of sweat, I have to kick all the blankets off, I have to change my pajamas. Some women take a shower, some used to go stand outside, so that's very uncomfortable and they've got difficulty falling asleep. For a couple sometimes it's difficult because the men wake up and they get irritated because the women wake them up kicking and undressing and changing, and air conditionings in rooms go on and then it's off.
Yeah.
So the night sweats is very uncomfortable as well.
Yeah.
But typically there is a pattern. There are also triggers to night sweats. And one of them is if you have high caloric diet intake at night, because calories literally means heat, and you need to burn calories. So if you have
sense.
hot drinks or alcohol or spicy foods or a high carbohydrate meal before you go to bed, that will trigger more night sweats.
That's so
because
interesting. It's actually it makes common sense, actually.
yes, you need to
Yeah.
burn your food,
Yeah.
whatever you eat. So
Yeah.
try to make your suppers a bit more lightly
Lighter,
if you
yeah.
struggle. Right, then that's the menstrual irregularities, the vasomotor symptoms. The next is musculoskeletal. Now, what Dr. Claire said, this is head of toe. This is body aches and pains from shoulders to fingers, knees, hips, muscle aches, joint pains. And this is the result of your muscles that physically gets weaker, and it's an aging thing more than a menopausal thing, but it goes hand in hand.
Yeah.
So as you age, you lose muscle mass, and as you age, you lose bone mass. As you age, your cartilage ages, and a lot of it is estrogen dependent. And once you lose your estrogens, all of a sudden women say they wake up very stiff in the mornings. They can't open their hands. Or they used to be able to gym a lot. Now they can't pick up the same weight. So they all of a sudden become a bit weaker. A common complaint that I get in my practice is pertaining to gynecology, specifically urogenital symptoms. The vagina gets dry,
Yes.
very uncomfortable and very painful during sexual intercourse, sometimes often bleeding after intercourse because of trauma. And this is because estrogen, if there's a decrease in estrogen, the elasticity of the vagina decreases. With the urological side is that women tell me, doctor, I think my bladder is becoming smaller.
Okay.
And they have to urinate more frequently. It burns when they urinate. They get a sudden urge to go and they feel they can't control it.
Sure.
This is partially, once again, because of the elasticity in the vagina. The vagina needs estrogen. And if there's not enough estrogen, your bladder doesn't have enough space to expand.
Okay.
And it feels like your bladder becomes smaller.
Yeah.
And you have to go more frequently, wake up at night, or you get that sudden urge that you need to go immediately. It also the dryness leads to recurrent bladder infections, because the mucus in your vagina is a barrier that sort of traps bacteria. And once you lose that barrier, the bacteria gains entry into the bladder just so much more easier, and that's why you get more prone to infections. And that becomes a big irritation to some women.
Yeah.
Yeah, so then very distressing to patients is a range of psychological and mental health issues. Most commonly complain of brain fog, memory loss.
Yes.
Literally women who's looking for their glasses on their faces, or looking for their keys while they're holding their keys in their hands. Sitting in a meeting, know exactly what they want to say, but the words are gone. So that's the typical brain cloud of cotton wool in the head. There's just nothing happening. Then the mood instability, the depression and anxiety that comes with it. Suddenly that creates some insecurity. You just don't feel yourself.
Yes.
The menopausal mood changes is very similar to what a girl would experience when she's a teenager and she goes into PMS. So your estrogen levels are nice and high when you ovulate, and then it suddenly drops, and then you cry for nothing. Yes. You fight with your best friend, no reason at all.
Yes.
And the same happens in menopause. Your body's used to a lot of estrogen in your brain. All of a sudden there's nothing. But now it's not a 2-3 day episode. Now it becomes permanent. You
thing,
cry for
yeah.
nothing. You're irritated at the world. You're aggressive. You're moody. And it's a complete emotional roller coaster. And this affects families, this in the home, because children don't know their mothers. Why is she shouting at me? Or husbands like, what is she doing? And it's so it does impact on your relationships. And often women don't realize it themselves. I often hear in my practice is, my husband says that I'm difficult. My
Yes.
children are avoiding me.
Oh, shame.
My colleagues don't want to sit with me in the tea room.
Oh.
And they don't even realize that their whole emotional behavior has changed. That this can lead to panic attacks and insecurity. Now, what we also see with menopause is, and this comes with night sweats, but not often just the night sweats. It's the night sweats, it's the weakness in your muscle strength, is the severe fatigue. So the night sweats, if you wake up 6-7 times a night and you don't get 6 hours of sleep, you're going to be tired in the next day. And the extreme fatigue makes people withdraw. Ek is nie meer lus nie. Doctor, I just don't want to do stuff anymore. I'm too tired. I get home from work, I just want to sit down with my feet up. And the fatigue is what gets a lot of women. The fatigue also influences your performance at work. You're just too tired to do stuff. The fatigue also, I mean, you know from lots of studies in, for instance, world wars, that sleep deprivation, it's used as a method of torture. So sleep deprivation can make you feel insane. And the fatigue then once again impacts on your quality of life. It goes with headaches, with feeling dizzy, with palpitations, and the list just goes on. Now, bone health is also a complaint. A lot of women are lately being made aware via social media about bone health and the prevention of osteoporosis.
Yes.
Now, your bone, your day-to-day bone turnover is estrogen dependent, and you get a decrease in the normal bone turnover when your estrogen drops. Now, this is not suddenly. You're not going to go from strong, healthy bones to osteoporosis overnight. This is a gradual process. But once you have osteoporosis, this cannot be reversed. So it is good to prevent the osteoporosis. So we see the slow bone loss, and the same happens to the muscle mass. And that's our general complaints.
You say that's general, but that's really a lot. And I mean, it just elaborates on the fact that menopause is so much more than just a few hot flashes and a few night sweats.
Absolutely.
It's really life-changing.
Yes.
And it impacts us on a much deeper level than just an hormone imbalance. So can you elaborate a bit more on how menopause or perimenopause symptoms can affect things like our heart health and our metabolism and so on, maybe?
Yes, we spoke a little bit about bone health and muscle health that decreases. Now, our estrogen is cardioprotective, and that's the reason why less women than men would get heart attacks.
Okay.
And women live longer than men in general because estrogen is protective. But one loses that protective effect eventually when you are a long time without estrogen. So with age, we see the development of high blood pressure. Women develop high cholesterol. You develop a condition called atherosclerosis, which basically means hardening of the arteries and the blood vessels, and that impacts on your circulation, and you develop poor circulation. Now, estrogen maintains the elasticity of the blood vessels, and it maintains your circulation, and it is a known fact that women on estrogen has got less cardiovascular disease than women not on estrogen, and suffers from less ischemic heart events or heart attacks than women not on estrogen. In fact, a cardiologist now, I have a lot of cardiologists in my area that refers their patients to me for estrogen therapy if they have cardiac health issues.
Okay, that's very interesting.
Your metabolism is another thing. Now, menopausal weight gain is real. It's not a myth. It happens to everyone. There's actually a term that's called the middle age spread, and it is contained in medical textbooks and medical articles.
Okay.
Yes.
It's a bit harsh, but okay.
It's hard. So low estrogen typically leads to a redistribution of body fat, and it's a major cause of increase in abdominal fat. So the first thing is women say, doctor, I'm gaining weight, and it's from year to year. They indicate between their breasts and their lower abdomen. And you get this round little tire that everybody is, I am uncomfortable with this.
Yes.
So it's not necessarily weight gain in a lot of kilograms, but more the redistribution of fat, which makes that your tiny little waist that you had when you were 18 disappears and you become round.
Yeah.
You get your little muffin top. Now, to help with this is, first of all, diet. You have to be strict on yourself if you get older.
Yes.
When you're 18 and you run around and you are very active, you can eat whatever you want to and you will maintain that little waist. When you're entering the peri-menopause, as from your 40s, you'll have to follow a more careful diet. Now, the typical diet we recommend during menopause is the Mediterranean type of diet, and then exercise, very important. A sedentary lifestyle, even though people will say, I've always been thin and I never exercised, now I'm gaining weight. You have to exercise for your cardiac health, but to maintain that calorie balance of intake and output. And the current recommendation is 150 minutes of moderate exercise a week. So not strenuous. Moderate is a fast walk, it's a cycle. And 150 minutes means 5 times 30 minutes.
Yes, that's not a lot.
If you want to do it in a shopping mall, this is not a slow stroll window shopping, but go to your favorite place and do a fast walk for 30 minutes. Join a group of friends, walk a dog, or something like that. You don't have to hit the gym all of a sudden when you hit 40.
We should really not do any vigorous cardio anyway.
No, so 150 minutes a week, moderate exercise. And then maybe twice a week, a little bit of strength training.
Yes.
But not excessive. You do not have to become a bodybuilder.
A bodybuilder. So when I listen to you speaking, it becomes very clear that women of, between 40, 50 really need to prioritize their health. I think it should become a non-negotiable when you hit peri-menopause and menopause. But there is help available to women, and one of the options that is available is, of course, hormone replacement therapy. So what is it that you would like women to know about HRT as a option for managing their hormonal imbalances?
Good. Menopause is not a disease. This is a stage of your life and everybody gets it.
Yes.
So to treat it with medication becomes a personal choice. The main goal of hormone therapy is, number one, improvement of quality of life. You've heard about all the symptoms, and it does decrease your quality of life. The second is to prevent certain diseases of aging, like osteoporosis and cardiovascular disease. And lastly, to maintain mental health. Mental health deteriorates over a time, and it's a slowdown. And once you're in a deep depression, it's very difficult to get you out of that depression with hormone therapy, and this is preventable. Also, cognitive health. Women who use hormone therapy are at least at a smaller risk of developing Alzheimer's and dementia, and that has been scientifically proven. So the best time to introduce hormone therapy is within the first 10 years of the onset of symptoms.
Okay.
It does not help to induce the hormone therapy in a woman in her 60s that says, now I've got osteoporosis, my mental health is a problem. It is too late. The tissue has already adapted to be not responsive to estrogen. So we call this in the medical world the window of opportunity, and that's that first 10 years. Preferably before you're 60, to initiate therapy, and then to go on as long as indicated and as long as you can tolerate, or as long as there's not a contraindication to it.
Okay, and I love what you said about, women have the opportunity to choose for themselves what it is that they want. So not everybody might choose HRT as a method, but for those that are interested in, taking up HRT, what are the benefits and what are some of the risks involved in using HRT?
So in general, it is very safe to use HRT under supervision, and in my opinion, the benefits far outweigh any of the risks. So the pros is to alleviate your symptoms, to make you feel better. It improves quality of life. It prevents diseases of aging, such as osteoporosis, dementia, decline in cognitive function, and overall it improves mental health. It can be called the ultimate anti-aging drug, but we're not allowed to call it that. Okay, so the cons. Any medicines with positive effects can have adverse effects. And this goes into the patient's personal medical history. If you have a risk of developing deep vein thrombosis or blood clots, or if you have family history of vein thrombosis, blood clots and strokes, if you're a heavy smoker, if you're obese, if you have a sedentary lifestyle, then you have risks of developing blood clots from hormone therapy. Some women, because of the molecules that is, it's synthetically made molecules, can develop severe migraines, and migraines in general is a risk of developing a stroke. So we need to evaluate your stroke risk before we introduce it to you. Some of the side effects, and this is breast tenderness. I see a lot of patients developing breast tenderness on hormone therapy, and typically those are the women who have waited a long time to initiate hormone therapy since the start of their symptoms, because their breasts become insensitive to the hormones, and then suddenly we introduce a lot of hormones, and there goes the breasts, like PMS, or when you're pregnant, that first sign is congested breasts. That's just the hormones. That doesn't mean it's harmful to your breasts. Your breasts will get used to it. Some women experience headaches from the hormones, and usually that's a dose-related thing or a molecule, and we can just adjust. Some women have a little bit of water retention from the hormones, and some women can develop an increase in their blood pressure. All these things are side effects from certain drugs. Now, if you, for instance, are on an antibiotic and you develop a rash, your doctor will say, well, let's go to another antibiotic because we still need to treat your infection. If you are on a blood pressure medication and you develop side effects, your doctor will not say you can't use blood pressure medication. It will introduce you to a new drug. There is no blood test that can tell me what medication to give you. It's like trying on shoes. If you're a number 5, you can't just pick it from the shelf and walk in it. Sometimes you pick your number 5, you walk a bit and it starts to hurt your toes and give you a blister. Then we need to change it. So there's lots of different formulas that we can work around side effects. But real cons, besides the blood clot risk, and this is in patients who have a familial history or a personal history of blood clots, there are very little risks. Now, people are going to ask me about breast cancer, and we're going to elaborate on that just now.
Yes, we are. That was actually my next question, because I do know that a lot of women fear that hormone replacement therapy can cause breast cancer. Maybe they just misunderstand. So definitely I would love your input, and also just to know, what does the science say about the link between HRT and breast cancer? What is the science, the new science saying?
The new science. I'm very happy that you say new science, because there's new science and old science. Right. Breast cancer is the most common cancer in the world.
Sure.
You can check me up on this. WHO data suggests that 1 in 8 women in their lifetime will develop breast cancer.
That's an astonishing number.
It's an astonishing number. In fact, everybody knows somebody with a breast cancer. If you have enough friends, you should have a friend with breast cancer.
Yeah, that's true.
If you have enough family members, you should have a family member with breast cancer. It's just because statistically, 1 in 8 women in their lifetime will develop this disease. And according to the WHO data, this is with or without a background history of family with breast cancer, and this is also with or without the use of hormone therapy for menopause.
Okay.
Still 1 in 8 women gets breast cancer.
Yeah.
So the commonness, now in my practice I only see women older than 40. I see 1 or 2 patients with breast cancer per day.
Sure.
I can tell no difference in the amount of hormone users and non-hormonal users. And in fact, most women who develop a breast cancer has got absolutely no family history, and they thought that they were not at risk. So everybody are at risk because we have breasts, and as long as you have breasts, you are at risk of getting breast cancer. So more than 80% of breast cancers that we do diagnose are hormonal cancer, and this is the nature of the tissue. This is estrogen and progesterone sensitive tissues.
Okay.
That's why your breast gets sore when you have your period.
Yeah.
That's why your breast gets sore when you're pregnant. So certain hormonal changes, you will feel it in your breast because your breasts have hormone receptors.
Yes, okay, that makes
So
sense.
most breast cancers will be hormone tumors.
Okay.
That does not mean that hormones cause breast cancer.
Okay.
If you do incidentally have a breast cancer and it is a hormonal breast cancer, the hormones will certainly contribute to the spread or the growth of the tumor if it's a hormone-sensitive tumor. That's why early detection is key. That does not mean that if you don't use hormones that you're protecting yourself against breast cancer. You're going to get breast cancer, as said, because you have breasts, not because you use hormones. Now, there is an unnecessary regurgitation of studies that supposedly say HRT causes breast cancer. And yes, there's some truth, but please remember that not all HRTs are the same. So the most commonly quoted study is a study that was done in America called the Women's Health Initiative. It was done during the late 80s, 90s, and it's been published in the late 90s and early 2000s. This study showed an increase in breast cancer risk in women who use a combination of progesterone and estrogen.
Okay.
But unfortunately wrongly accused all progesterones and estrogens because they only tested one drug. This drug I'm going to name, it's a drug by the name of Primel. It was a combination of medroxyprogesterone acetate and combined equine estrogen. This drug has not been available worldwide since 2002 because of this study. Now, we can't say that because Primel caused breast cancer, that any of the other drugs will cause breast cancer.
Yes, I hear you.
It is like you just cannot compare the Mercedes-Benz that one person drives to a Kia Picanto that another person drives according to safety profiles. So they're
Yes.
not all the
same, yeah.
So the newer studies on the newer drug does prove a lot of safety. So there is a lot of development and research that went into the safety of HRT with regards to breast cancers. So what is proven now is that if you use estrogen alone, and that can only be used in women who's had a hysterectomy,
Okay.
it decreases your risk of developing breast cancer.
Okay, very interesting.
Not very significantly so, but we see almost an 18% reduction. Now, 18% of 1 in 8 is not really a lot.
Yeah, but
Yeah.
it's something.
Yeah, so it might make 1 in 9
Yeah.
to develop breast cancer,
Okay.
or 1 in 10.
Yeah.
So one can't, but yes, we do see a decrease in breast cancers in women who use estrogen alone.
Okay.
Now, estrogen alone, once for a woman who's had a hysterectomy, or our very good alternative that we use now to hysterectomy is to place an intrauterine progesterone device, commonly known as a Mirena. So the Mirena can be like a hysterectomy, and then you can use estrogen alone, hormone therapy.
Okay, that makes
Right.
sense.
The transdermal estrogens, and this is the patches and gels that everybody talks about, has got no effect on your breast cancer risk, and that has been proven. Bioidentical progestogens and bioidentical estrogens has got no increased risk on breast cancer development. So still 1 in 8. Right. Certain oral combinations doesn't have an impact on the overall risk, but we do see in women who has used a combination of oral estrogens and progestogens for a long term can have a slight increase in developing breast cancer, and this is if it's used longer than 10 years. Okay. In the modern practice now, we all switch women over to the safer combinations. So to use a combination of hormones for 5 to 10 years does not increase your risk. But after 10 years, we have to start to think about transdermal or bioidentical routes if you want to continue, and then you are safe.
Okay.
Now, once again, if we say that some of these progesterones or progestogens causes an increased risk after 10 years, we might take you now from a 1 in 8 to a 1 in 7. It is not double the risk, triple the risk. It's a slight increase. I urge all my patients on hormone therapy to do breast cancer screening in the form of mammograms.
And that brings me actually to my next question, because I think if women know that they can be in charge of their health, ask the right questions and ask for the right tests and screens, it empowers them and it puts them in control. What are some tests and screens that you recommend women can go for or take as part of them managing their menopause symptoms and their health?
Right. So, as said, the fact is everyone is at risk of breast cancer, 1 in 8 women. So, with or without HRT, if you're over 40, you need to start breast screening. So, in a low-risk population, which most of us are, we recommend screening every second year.
Okay.
And a high-risk population, we would recommend yearly screening. I'm not going to go into who's high risk and who's low risk now. That is for you to discuss with your physician. Just once again, as I wanted to say, avoiding HRT does not decrease your risk of developing breast cancer. So please still do the screening. So that is the most important one, is the mammograms. Secondly, pap smears. Cervical cancer is a common cancer in women over 40. And there's a new test now called human papillomavirus screening. Human papillomavirus causes cervical cancer. And if you screen negative for human papillomavirus in your 40s, you actually only have to do a pap smear every 5 years, and not the yearly as before.
Yeah.
Because we know cervical cancer is caused by papillomavirus. If you test positive, this is not a disaster. Very few women with the virus will develop cancer, but they need to do annual screening then with pap smears.
Okay.
Then in general, your thyroid. Thyroid is a silent disease and it goes with menopause, and the symptoms are overlapping. Thyroid causes fatigue. Thyroid causes sleeplessness. Thyroid can make you flush.
Okay.
Thyroid can cause depression and anxiety. So the symptoms overlaps, and I think that you need to have regular screening for thyroid disease, as it is quite common in older women. Diabetes, also a silent disease with exactly the same symptoms as menopause, especially the fatigue, the weight gain, the flushes, the sweatings, the can't sleep, the depression. So we need to screen for that. And another one is cholesterol. Cholesterol, silent disease. Nobody has symptoms. And if you don't know that, you won't know that you have cardiovascular risk. And you need to do something about it. You need to go to your GP maybe every second year to just check your blood pressure, because that is a silent, also asymptomatic disease that women get nothing to do with menopause. It's an aging thing. Women get high blood pressure. So check for that. It is not necessary to do full blood panels for liver function, kidney function, vitamin status, all sorts of blood counts on an annual basis. Those tests screen for diseases that are symptomatic. If you have kidney disease, we will screen for it if you have the symptoms. We will screen for liver disease, so it's not necessary to do an annual full panel. I think it's a waste of our resources regarding medical aids to do full panel blood tests. Then lastly, bone density. If you have a family history of osteoporosis, you need to start your screening at 50. We don't screen women younger than 50 because there's no standard of screening. We've got nothing to compare it to, so the values are not accurate.
Okay.
So first bone density at 50. Now, if there's no one in your family with osteoporosis, you don't have to do a screening test at 50, then you can start at 55.
Okay.
So typically, we screen at 50, 55, and 60, and after 60, this becomes frequent testing. But if you're a younger woman, 50 or maybe even sub 50, and you have known diseases that's associated with osteoporosis, like chronic kidney disease, thyroid disease, you've had asthma and you've been using cortisones, you've had lung disease, you've had some autoimmune disorder and you've been on cortisone since your 20s, then you need to screen. But a normal, healthy woman does not have to screen before she's 50.
Thank you very much. I found that piece of advice so empowering, and I think it's important for women to know that they have the right to ask questions, and giving them the correct guidelines so that they can get the information that they need also just brings them some calm and some clarity. So thank you very much. But I do think that we might have left the listeners a little bit overwhelmed by now.
Of
We've
course,
shared
it's lots of
so much
information.
information, total overload. So let's just give them one step. So what is the most important piece of advice that you can give the listeners that you want them to take away from today's episode?
My advice is that you equip yourself with real knowledge and not the type of hearsay stories that you hear from your grandmother in the hairdresser or in book clubs. Equip yourself with real information. Stay healthy. Diet, exercise, and avoid alcohol, smoking, and vaping when you get older. And if you are not coping with your transitioning symptoms, seek help earlier rather than later. The earlier we start you on treatment, the better our overall outcomes will be.
That is excellent advice. Dr. Bianca, thank you so much for being here today and really for taking time out of your extremely busy practice to come and educate us, and thank you for the careful manner that you've shared the information to us today.
Such a pleasure.
I really appreciate you being here.
No, it's a pleasure. Thank you for asking me. And then lastly, I just want to say, do not be scared of menopause. This is not a disease.
Yeah.
It happens to everyone.
Yeah. Thank you very much for that. And to everyone listening, I hope today's episode reminded you that you are not alone and that there is nothing wrong with you. Like Dr. Bianca just said, perimenopause and menopause are natural phases. And with the proper support, understanding and care, you can move through them with strength and confidence. And remember, as a health coach and a kinesiologist, I would love to walk alongside you and your doctor to support you on your journey through this transition. Working with a health coach can help transform a life of neglect into a life filled with self-care, resilience, and balance. And you are so welcome to book a coaching session with me, a complimentary Becoming You at 40 coaching session. This will give you the opportunity to explore my services and to see how a coaching program could benefit you. You'll find the link for this in the description box or visit www.tayenucare.co.za. And if you found today's conversation helpful, please share it with another woman in your life because knowledge is empowering. Dr. Bianca, where can listeners connect with you or learn more about the work that you do?
So I am not on social media.
Okay.
I like to take a personal approach. So my practice is situated at Life Groenkloof Hospital, also known as the Old Little Company of Mary Hospital. It's in Pretoria and Groenkloof. And my practice phone number is 012-346-4564, or you can email us at admin@drbzondach.co.za.
Thank you. I will leave your email address also in the description box for the listeners.
Thank you.
So thank you for sharing that with us. Thank you so much for joining us today. I'll see you in the next episode where we continue exploring the science, the stories, and the support that help women thrive. Until next time.